Hola, buenos dias everybody. Hello to you. My name is Ffion Davies and I'm the President of the International Federation for Emergency Medicine, IFEM. I speak to you from a hotel room in Malaysia, Kuala Lumpur, where I've just arrived from the UK, which is where I work. I'm so sorry I can't join you live, but it's already 8:30 p.m. at this time and I have to be up at 4 o'clock in the morning for a connecting flight. So I know you're going to be live in 2 hours' time. I'm so sorry to miss you, but I wish I was there, able to engage with you and answer questions. So the topic, as you know, is about overcrowding, and this is truly a global problem. You think it might be your hospital, your bosses, your government, your local health policy makers. It's universal, it's all over the world. So I want to talk to you about IFEM's global campaign against overcrowding. So back 4 years ago, IFEM wrote a report which was about overcrowding, particularly access block, not being able to get the patient into the ward in the hospital. When we looked at this again, we thought this doesn't need rewriting. Sadly, everything it says is still the same. What it needed was a campaign. We needed some energy behind this. And really at the end of 2022, in many countries, things were getting really bad, much, much worse than they'd ever been before. We were seeing this throughout USA, Canada, UK, Australia, New Zealand, scenes like we've never seen before in our emergency departments. And what are the causes of overcrowding? Well, you all know this, so we won't spend time on this slide. But sometimes too many patients arrive and it's not the right kinds of patients. We're getting the patients that can't find somewhere else to go. Sometimes our processes are not as good as they could be, bloods, imaging, whatever the problem is, or your ED really truly is too small, but that's not often the case. The most common problem is insufficient in-hospital beds, and that affects most of us. So it's a universal problem with different causes in different places and a different balance of causes in different places, but really the same root cause and the same end result. So in November we decided we were going to run a campaign, and we wanted to launch a campaign with a toolkit that anybody could use for their own particular situation. And it was taken up very well, I'm so pleased to say, and I'm very, very grateful to Flame, who took it up with passion, and other regions did the same: North America, Europe, Africa, Asia, and Australasia. You can see all the social media impact we'd had even by the 1st of March, and the campaign still rolls, and we will talk about that some more later. So the toolkit that I mentioned, it had a press statement you could use for the media, for TV, radio, etc. It had a policy statement, which is still on the website, so you can see that if you need the support of the international community, we have a strong statement to say that overcrowding is dangerous, it kills patients, it's unacceptable. We created posters, you can see the first poster there. We decided to create 2 posters. So the first poster that we issued took the more emotional angle, so that anybody reading this could not possibly feel that this was okay for a child to witness somebody dying in pain right next to them. That's not right. Any human being would agree with that. And the hashtag we used for this was "No More Lives Lost Waiting," and we appealed to the public and the healthcare policy makers that this is a dangerous situation. The second poster that we produced made the strong message that overcrowding is unacceptable and avoidable. And when you look at the causes, there are many causes that contribute to overcrowding, but I honestly think that there is a deep human psychology to it. The patient has an emergency, and therefore, of course, everything that happens next must be chaotic and unpredictable. And we know that's not true. Emergency physicians know that we can plan. We know, just like an airport knows, if I say to you, how many patients do you usually see in a week? How many strokes do you see in a week? How many major trauma cases do you usually see in a week? We all know the answer for our department. So the people that contribute to this cause, the causes of overcrowding, the healthcare policy makers, the hospital bed managers, we need to show them data. We need to show them what goes in, what's in the middle, what goes out, and that it is predictable, it is fixable, it is possible to change, it's not unacceptable, and we can make this happen if we work together. So that was the second hashtag, Reset Emergency Care. This is not normal. Unfortunately, we all get so fatigued that we normalise it too. So in my department, some days there are only 3 ambulances waiting to offload patients at the moment. And we say, oh, today is a good day because there aren't 20. And we are just as guilty of allowing this to be normalised. So one of the purposes of the campaign was to show solidarity with all of you. We are all in this boat together, but we all really need to fight, and together we are stronger, and maybe we will have the passion to fight the problem instead of just having to accept because we're so tired. So shall we do a little tour around the world to get the view from the different countries? So we've had some summits and webinars to discover each other's problems. I've sent out a survey. We've had questionnaires and feedback. Very good engagement from many, many countries. And these are some of the things I thought you might be interested in that happen outside Latin America. So in the USA, we asked, what are your major problems? And they said staffing shortages, especially nursing, not enough bed spaces, hospital beds are used for elective surgery, which brings more money. They have a real problem with patients with mental health emergencies, especially opioid addiction. And they end up treating sick patients in the waiting room, patients dying in the waiting room, doctors, nurses burning out, and patients coming to harm. So the American College of Emergency Physicians wrote a statement and a letter, very detailed letter to the White House, to President Biden in December. And in it they had stories, real stories from real nurses saying how bad the situation was, finding patients in the waiting room, face down, cardiac arrest. It was quite a powerful letter. So with that, they found that they did have more coverage in the media. They are now organising stakeholder summits with politicians and people at a higher level than they were engaging with before, because people were showing an interest, and people, the senators and the people they were engaging with, realised that they had a problem. And I honestly believe that if you have a problem with your voting public and you're a democracy, that's when the government will listen. So utilise the media, utilise the every channel you can, TV, radio. So let's go to Canada. Here's a picture from Alberta State, and their biggest problem is lack of hospital beds. The length of stay at the end of 2022 had suddenly astronomically gone up. What were the reasons for this? Well, it wasn't the number of patients coming in. Year on year, this is about the same. A little bit less, in fact, and we've seen that in the UK. Pandemic year, when COVID first hit 2020, we all saw fewer patients coming in, and then there's a bit of a recovery to normal, but only just coming back to pre-pandemic levels, so that's not the cause. Their admission rates, had all the doctors suddenly had a crazy idea to admit all these patients? No, nothing changed. So it's quite interesting in some countries, including my own in UK, what is it that's changing? So again, they took action at the end of 2022, and the waiting times is now a government priority. They have within the hospital a 35% bed weight trigger, so that suddenly higher level managers are involved as soon as the number of patients waiting for beds is 35% of occupancy of the ED or more, and various other things. So particularly patients who are elderly, who are able to go to a long-term care facility, they started zero tolerance. You cannot not take these patients. So that there was zero tolerance at the other end of the ambulance zone, being like a car park full of ambulances with patients in. They also developed a dashboard, and this is a public database, so any member of the public in this part of Canada can see the waiting times in all the emergency departments in an atmosphere of transparency. And we have seen that in the UK. If your hospital managers can see that up the road this way and down the road that way, they're doing better, it motivates them to do better for your hospital. So that might be something you might already do or want to consider. Thank you again so much to Flamme for taking this campaign and really running with a passion. translating it, putting it out there on social media. Thank you to Drs. Daniel Lopez and Daniel Sanchez for taking up the media. How many TV interviews did Dr. Sanchez do? Fantastic. So thank you so much for that. So I'm not going to spend time on your causes and your solutions because you know that. So let's go to Europe. Within 2 days of the IFEM campaign, our regional representative Maret from Finland reported that they'd made the headlines, which was fantastic. I'll give you a pen picture from the UK. This is kind of what it looked like at that time, end of 2022. Now, this is not my department, but mine was identical. All these ambulances in the car park with a patient inside, and they had all called, in our country, 999 or 112 in other places. So these are true emergency patients. This is not primary care, in a vehicle, so that people like me at consultant level had to put on a high visibility jacket and be the ambulance doctor for today. Crazy, crazy, crazy. And all they did in our car park was make the car park bigger. You don't want to make the bath bigger. You want to make the flow better. In the UK, it's not a problem with primary care. We also started a 4-hour target, you may have heard, back in 2004, a long time ago now. As a result of that, patients were meant to come in and be out to a destination or home or a ward within 4 hours. We went through a period over that next 10 years where we had very good flow. It also made us very good at our processes. So our processes in the ED is not the problem. Our problem is staffing, large numbers of shifts that are vacant, large amounts of money spent on filling shifts at a superior rate to attract the staff, and the real problem is blocked beds, not enough beds. Partly because elective surgery is given priority, like the USA, partly, in the main actually, elderly patients ready to go to the next destination, medically fit, nowhere to go, because our care homes took a real hammering during the lockdown, and they lost a lot of staff, and their staff are very low paid. So some of the successes we had were having dedicated staff in the ED called flow managers, and they help take the problem. You can't find the orthopaedic surgeon, they'll find the orthopaedic surgeon, etc., etc. The blood gas machine has broken, they get it fixed. These sorts of things. Having a hot lab in the department with a blood technician, if you're a big unit, who does the bloods there and then. We have very sophisticated tracking systems. We know exactly how many patients in the department. It refreshes the screen every 30 seconds. You can task the nurse to do an ECG without even finding the nurse. Very sophisticated technology, and still we have the problem. And that's what I mean about the psychology of it. We even had our president, Dr. Adrian Boyle, went to the Prime Minister's office twice this year. We still have the problem. I apologise if I'm getting you depressed. Switzerland, let's go around Europe. Root cause is there, lack of doctors. So they can't staff the emergency departments. And actually, this also happens in Canada and Australia, with many rural departments and just not enough emergency physicians. Pretty similar across the border in Italy, but they have a lot of problem with bed capacity. Same with staffing and having to pay a lot of money to get people to cover the shifts. Any successes in those countries? No, not really, but the emergency medicine societies of these countries, which are really quite new. You might think that Europe has had emergency medicine for a long time. It hasn't. The UK has, but most countries are new to emergency medicine. It's the status of the specialty is the problem, and not enough emergency physicians being trained because the government doesn't believe in investing in the training or doesn't recognise the specialty, and that's in many countries in Europe. So let's go on to Asia and have a look at India. So the problems there are more to do with primary care. So the outpatients and primary care patients end up in the ED footprint in the space, and they have a similar problem with lack of skilled staff, nurses and doctors. They also have not had the same investment into rapid imaging, rapid blood tests, and they have a real problem with critical care, so that patients are staying in the ED in some hospitals 2 or 3 days until they get better. They no longer need the intensive care bed. They had a good success story in Mumbai, where they employed, quite expensive experiment, 6 new managers with MBAs, and they looked at all the processes. They emptied out the waiting room of relatives and wheelchairs and trolleys. They said to all the staff, like the porters, you need to do this, you need to work quicker, you need to do your job, without the doctors and nurses having to come into the conflict. They trained them to do things like tell the triage nurse, if you have anybody arrive with a chest pain, alert me and I will make sure I take them to the next room, they get immediate ECG. This has been very successful. We have a similar process in the UK. Ethiopia, well, they had an interesting experiment, and this is part of the human psychology. This is another good tactic. In their waiting room, they created an area and said to their acute internal medicine doctors, this is your space. You can have it. You can have our space. And suddenly the internal medicine doctors found themselves looking after the patients in the waiting room, realising that's not acceptable, making sure they went to the wards quickly, making sure the discharges happened quickly to accommodate the new patients. And 3 weeks into the experiment, the waiting room, which was normally chaotic, looked like this. That's all human psychology. South Africa has many problems. It's having regular electricity supply problems. There are big problems at government level, roads and infrastructure level. They have a large migrant population that sees South Africa as the rich country, so they come across the border, no insurance, no ID card, they can't get any treatment anywhere else, so they have to come to the ED. We were told of a story in Johannesburg. A patient had been in the ED for 3 months because they didn't have a South African national ID card and they had a mental health problem, so nobody would take them. So big problems there, and real limited capacity of the hospitals, a big difference between public and private. So the public hospitals really suffer. They were saying that some of the drug-related mental health problems can cause up to 25 patients to be in the ED just in psychosis at any time. They also have stock and equipment shortages and a limited budget, which seems to decrease annually, and big staff shortages through burnout, and sadly many of their doctors and nurses travelling abroad and leaving South Africa forever. They have increased the capacity and the skill level within their satellite units of primary healthcare. That's been successful, and they now have all public emergency departments, I think, using the new national triage score which their own professional society designed. If we go to Hong Kong, these are regular daily pictures in Hong Kong. It was even worse during the COVID pandemic. They had to actually treat patients in tents or on trolleys outside the ED. Unfortunately, the death toll was so high, particularly the elderly population who had been not vaccinated quickly enough. The bottom left picture you see here in the grey bags, those are dead bodies. In Hong Kong, they have a high daily attendance rate per population, and most of this is because of inadequate primary care, but they also have the brain drain to other countries where the staff leave and don't come back, and just people not signing up for shifts. So they put a superior rate of pay on their own staff coming to fill shifts, but not so high on other staff, so that they're more likely to fill the shifts with people they knew who had the right skills. That was a good initiative. They've also been putting out a public appeal. They want to do the same in South Africa to encourage people to find other places of care. They've put a geriatric specialist at the front door because they have quite an old population, to get people to accept that sometimes you can be ill but not require admission to hospital. And they've got a system like we have in my hospital, which is called Gold Command, where senior managers and very senior executive officers of the hospital can say, we are opening beds here, we are going to have more staff there, and make sure that we take patients from the emergency department. Over the water in Thailand, overcrowding has been a common problem for several years now. They've tried various strategies, pre-hospital, in-hospital, expanding spaces, expanding the workforce, making some progress, particularly ambulance diversion to spread the workload around the hospitals in the region to have a coordinated response, and identifying patients quickly at the front door that can go somewhere else. And we use that a lot in my hospital. so that a very experienced nurse sits at the front door and doesn't perform a full triage if it's very clear the patient could go somewhere else. They've also been using a media campaign, social media, and a lot of telemedicine. And this is an interesting topic we don't have time to discuss, but I wonder if this is the future for some countries. There's a lot of interest in the emergency physician as a generalist giving advice over phone, video as well if needed, and being able to avert attendance to ED. So to sum up the common themes around the world, a lot of countries are struggling with the ageing population and an expectation that every deterioration should be treated in hospital with IV therapy, and a lot of problems with mental health patients, particularly since the pandemic. So the next steps for IFM are that we are going to develop a useful tips document, and that will be added to the toolkit with real practical suggestions for how to manage different situations. Please continue the campaign in your area. Please continue to use those hashtags. If you have good ideas and examples of success, please use overcrowding@ifm.cc to share, and we will have all the top tips and helpful hints up there on the website. We want everybody to contribute to that. Particularly if you have stories, you have pictures, please share them. The next thing that happened was 2-3 weeks ago, the Asian Society of Emergency Medicine had an international seminar on overcrowding, which was fantastic. And then the European Society will have their campaign, which they have every year on May the 27th for EM Day. And this year's theme is patient safety, linking closely to overcrowding so that they follow on from the IFM campaign. So thank you very much for listening. I'm sorry I can't take questions live, but please use overcrowding@ifm.cc with your thoughts, your solutions, your stories, your questions, and we'd be very happy to keep this dialogue going. Thank you so much for inviting me to speak. I hope you enjoy the rest of your Saturday symposium. Very nice to see you all. Bye-bye.